Excellent. So, Assalamu alaikum, everybody. My name is Ibrahim Alodhaibi. I am a third-year medical student, and this is my third PAL lecture this year with you guys, I think. I'm very happy to be back here again. So today we're going to be covering two relatively simple topics. It's going to be airway resistance and assessing pulmonary function. Now, as per usual, if you guys have any questions for me, type them in the chat, and then if I don't notice them, someone unmute and interrupt me so that I can go back and notice them. Without further ado, Bismillah, let's get started. So the first concept that we're going to cover is not actually part of my lecture. It was part of Yazan's lecture yesterday, but I think it's important that we go over it together just because it's a concept that will help you guys sort of understand this lecture better. And that's what's going on in a normal breathing cycle. So what is happening in a normal breathing cycle? First and foremost, we always start the breathing cycle at the end of expiration, right? Which is at FRC. So the top picture, which is, I don't know why I'm using my hand. The top picture, which is this picture.
You're not sharing your slides.
I'm not?
No.
No.
That is for me.
Oh. Okay, you guys can see them?
And I think it's from you. Yeah. Okay, maybe it's a me problem.
Oh,
Go
okay,
on.
okay. Anyways, so the top picture is FRC, right? Which is at the end of expiration, right? So the transmural pressure, which is the pressure between the alveoli here and the pleural space here, is +5. Now, do you guys know how we got that number, right? So we did 0 minus -5, which is equal to +5, right? This presence of the pleural pressure, as Yazan covered in his PAL lecture yesterday, is what is causing the respiratory system not to collapse on itself. Okay, now when we begin the cycle of inspiration, what's going to happen is that we're going to have our muscles contract, right? Like the diaphragm is going to move down, right? And we're going to have muscles that are used for inspiration begin to do their thing. This is going to make the pressure that's present in the pleural space less negative. Okay, so we're going to go from -5 all the way down to -8. Now, based on the characteristics of the alveolar wall, they're very, very thin walls, which means that the pressure that is present in the pleural space is easily transferred to the alveoli. So what's going to happen is that the pressure in the alveoli is going to become negative as well. Now, air likes to move to the lower pressure. So after we finish inspiring, what's going to happen is that the air is going to come and equalize the pressure because air likes going to where there's lower pressure. We're done inspiring, right? Our diaphragm is fully contracted. We're in this picture now. Our diaphragm is fully contracted. We're done inspiring. The air came in and it equalized the pressure in our alveoli. It's time for us to start exhaling. So when we start exhaling, we're going to use, again, muscles. We're going to use our muscles, and that's going to create a less negative pressure in the pleural space, but a positive pressure in the alveolar space, which is, again, going to push the air out. So really the main idea here is that negative pressure, oh, I realized my markings cover that. Negative pressure in the alveolar space means air is going to come in. Positive pressure in the alveolar space means that air is going to come out. That's what's happening in a breathing cycle. Did we all understand that?
Can you repeat it again, please?
Okay, the whole thing or which segment did you not get?
Yes, the whole segment, if you don't mind.
No worries. So we start the breathing cycle from the end of expiration, which is FRC, right? In the end of expiration, we have a constant negative pressure in the pleural space, which is this space right here. That negative pressure is what's making sure that the lungs are not collapsing on themselves and that the chest wall is not expanding, right? As we learned in yesterday's lecture. When we go to inspire or take in air, what's going to happen is that our diaphragm is going to contract. So there's a muscle that's here and it's going to move down. This muscle moving down is going to create more negative pressure in the pleural space. That negative pressure in the pleural space is going to be transferred to the alveoli. The reason that the negative pressure is transferred is because the alveoli have really, really thin walls. So any change in the surrounding area, like around them, is going to affect them as well. Now that we have negative pressure in the alveoli, that's going to bring air in. So negative pressure brings air in. Okay, the air is going to go to the smaller pressure, the area of less pressure. So we're going to breathe in. Okay, did I cut out at all? Are you guys fine? I'm assuming yes. So you're going to breathe in. Once you breathe in, the pressure is going to equalize. Okay, and you're going to be the end of inspiration. So you got all the air in the body, the alveoli are back at 0, they're back at atmospheric pressure. Okay, now it's time for us to breathe out. The diaphragm is going to move back up. The negative pressure is going to become less than it was here because the diaphragm is moving back up. And also because of the presence of air here, right, we're going to start pushing the air out to exhale. And that brings us all the way back to the beginning of the breathing cycle. And this keeps repeating itself.
Yes, okay, I got it.
Okay. All right, I'm going to move on to the next slide. The next slide is pretty much the same thing, just in a different graph form. So on the left side of this graph, we have inspiration, and on the right side, we have expiration. Okay, so this first graph is looking at the volume. Obviously, when you're inspiring air, there's going to be more volume going into the lungs. When you expire air, there's going to be more volume exiting, and that's why the graph is like this. That makes sense. Here, we're going to look at the expiratory flow, which is basically the flow of air as you're exhaling. Same concept here. When you breathe in, the expiratory flow is going to go down because you're not expiring, you're inspiring. Okay. And when you breathe out, the expiratory flow is going to go up. Okay. Now this graph is looking at alveolar pressure. Now remember how I said here that when we're inspiring, the alveolar pressure is negative. Okay. So going back to this graph, we can see that when we inspire, when we're breathing in air, the alveolar pressure is becoming more negative. And then when we expire, the alveolar pressure starts to become more positive so that the air can exit. Because, can you repeat the breathing cycle? I was late. I'm going to go over it really quickly. So basically, the main idea of the breathing cycle is that negative pressure is going to bring air in, positive pressure is going to bring air out. Okay. At the end of exhaling, which is FRC, this is what's present in our body normally, this top picture right here. Okay, our pleural space has a negative pressure to prevent the respiratory system from collapsing on itself. When we breathe in, our diaphragm contracts, it moves down. It's going to make this pleural space more negative. The negative pressure in the pleural space is going to transfer to the alveoli due to the fact that the alveoli have thin wall. Negative pressure brings air in. That means air is going to come into the alveoli. It's going to equalize the pressure. All right. And then it's time to exhale. The diaphragm is no longer contracted. It's relaxed. There's a positive pressure in the alveoli. That's going to push the air out. We're back at the beginning. All right. Now, going back to the, where was I? Yes, this graph. So alveolar pressure, we said when we inspire, it's going to become more negative. Okay. When we expire, it's going to become more positive, like we just covered again. And then pleural pressure. Important for you guys to remember that pleural pressure is always negative. I'm going to write it here. Always negative. Okay. Pleural pressure is always negative. We need the pleural pressure to be negative so that the lungs do not collapse on themselves. And if you do not understand why we need this, please go back and watch yesterday's PAL lecture, as that concept was covered there. So yes, the pleural pressure when we inspire becomes more negative due to the diaphragm contracting. And then when we expire due to the diaphragm relaxing, it becomes less negative, but it's still negative. Do we understand that? These 4 graphs. All right, excellent.
Yes, thank you.
So now moving on to the actual start of my lecture, which is airway resistance. So airway resistance, we're going to start with this. So you guys are familiar with this equation. This is Poiseuille's law from hemodynamics, which is a lecture that Momo and I taught. And it's about resistance in blood vessels, correct? So that law is basically the same thing, is applicable to the respiratory system, but we can rearrange the equation to make it a lot simpler, which is this equation, which is essentially the pressure in the alveolar space here, minus the pressure in the atmosphere divided by the flow. Now, remember, the pressure in the atmosphere is a constant number. It's always 0, okay? It will always be 0. Most of the time, it will be 0. If you mess with altitudes and stuff, things might change. But for you guys, it's always going to be 0. Now, what is the key concept here? And it's the same exact idea as what was in Poiseuille's law in hemodynamics. is that the factor that can affect the resistance the most in airways is the radius. And you can see here in the denominator of this, we have the radius to the power of 4, which means that a small change in the radius is going to have a 16-fold change in the resistance. Okay, so what you need to understand here is not so much the equation, more so the idea that the radius and the radii of the airways and the bronchioles and all the things that go into the respiratory system is what is going to impact resistance of air movement the most. Okay, there are two ways that we can change the radius. All right, how can we change the radius? There are two ways. Let me see if any of you guys can guess the two ways, and then if not, I'll tell you guys. But how do you think we can alter the radii in the airways? Okay, so bronchodilation and constriction, correct. So that is the more active way to do so, would be smooth muscle activity. That's the simpler way to say it, is smooth muscle activity, which is dilation and constriction. The other way that we can change the radius and affect the airway resistance is by changing the transmural pressure, which is the pressure from the alveolar space and the pleural space. Okay, that is the more passive way, and that's kind of what's happening in the breathing cycle, right? Yeah, exactly. Transmural pressure changes. Good job, Hala. So we're going to cover these concepts more throughout the lecture. But do you guys understand this slide and the fact that the radius is the most important thing in airway resistance? All right, excellent. So moving on to the next slide. Here we have the branching of the airways and the lung volume. Now, this graph can be confusing because when I was looking at it yesterday while preparing for the session, I kept reading this graph from left to right, but this graph is meant to be read from right to left. All right, you're supposed to read this graph this way. Okay. The concept here is that the conducting airways, right, are made up of a system of branching airways that connect the atmosphere, which is like basically the outside world, with the alveoli in our lung, right? So we have these branching airways that go from where basically our mouth to our lungs. And this is what allows air to flow from the atmosphere to the alveoli. Now, what you guys need to understand here is that the first 16 generations, right? So like the first 16 divisions of these airways, because you guys know from anatomy that these airways are dividing into smaller things, right? So the first 16 divisions, and the numbers are not very important, the concept is important here. First 16 divisions are dead spaces, which means that they have no ventilation. The air is coming in here and pretty much nothing is happening to it, right? So you see how in the first 16 airways, nothing is happening to the lung volume. It's staying almost completely linear here. Nothing is happening. The reason for this is because these spaces have a small radius and they have increased resistance. And we're going to cover that more. So I want you to just keep that in the back of your mind. But the generations after generation 16, so moving from 17 upward to 23, right? These are the parts of the airways that have a larger radius, right? And they have less resistance to air movement. And because they have less resistance to air movement, they're able to, take up more volume of air and affect the lung volume more. I feel like the way I explained that was very confusing. Did you guys get that? It's okay if you didn't, because I wouldn't have gotten it. Really? Okay, I'll repeat. I was waiting for that. So basically, so you guys understand how the airways are constantly like dividing into smaller pieces from the opening of our mouth to our lungs, right? So the first couple of divisions or generations, what they call them, are dead spaces. That means that they could either be anatomical dead spaces or, actually, I'm not gonna get into that. They're dead spaces, which means that there's no ventilation happening. They're not really benefiting us for getting air into the lungs. There's nothing to happen to them. There's nothing happening to them. So see how the first 16 here in this graph are not affecting the lung volume at all. But the ones afterwards are having a significant impact on the lung volume. And the reason for this is because we mentioned that the radius, right, the radii of these airways are what the airway resistance the most. The reason these last to 23, the reason that these generation of airways do not or and then two from even they are smaller. If some of these airways to diameter is going to be bigger than anything before them, right? So that means they have a bigger diameter in total. A bigger diameter resistance, or a bigger radius means less resistance. Less resistance means more airflow. More airflow means an increased lung volume. Oh, I'm lagging. My bad.
Lagging, yeah.
Okay. Where did I last leave off? Am I lagging again? No. Okay, I'm fine now. So I'll just say the last bit. Basically, the radius, right, for the last from generation 17 to 23, even though individually they're way, way smaller, the summation of all of their radii together is way bigger than anything before it. And remember that a bigger radius means that there's less resistance. Less resistance means that there's going to be more airflow, less resistance to the airflow, everything is moving easily, you're going to have an increased lung volume. So that's why they're saying that the respiratory zone is from 17 to 23, because this is the section where it branches so much that the sum of all of their radii is really big and there's no resistance to airflow anymore. Is that clear? We're going to go over this concept again, by the way, like I think literally in the next slide. Okay. So in the next slide, so this is what's happening here. Resistance of airways. All right. Basically, what we're seeing here is that now we're reading the graphs from left to right, and we're going to start with graph A. So the first couple of airways, like, the branching of airways, have a lot of resistance, right? Remember that normally, just if you think about it, every generation of bronchi, the radius is getting smaller, because if you're dividing something, it's going to get smaller. That's logical, right? That's what's happening. But like I mentioned, the total diameter of the bronchi only decreases up until this generation, right? So when you're adding up the total diameter of everything in this generation, it's only decreasing up to here. Eventually you reach a point where the replication, or like the division of it, is so much that when you add all of them together, it's going to be greater than the one previous to it, right? So what's happening is that it's greater than the one previous to it. It has less resistance. That means khalas, the resistance to airflow now decreases with every generation, because there's so many that when you sum up all the radiuses together, they have a really large radius, a really large diameter, there's no resistance. So what's really important to understand here is that most of the resistance, right? Most of the resistance in the lungs is coming from the first couple of generations of airways. After that, like after the upper airways, there's almost no resistance to airflow, right? Do we understand this? All right. So there is a clinical significance to this. Okay. Now we understand that almost, like here it says 80%. 80% of resistance to airflow is in like the first 4 generations of airways, right? The upper airways. The clinical significance of this is that we can have something called a silent lung zone. And what that means, okay, someone said no, that they didn't understand. Which part did you not understand, so I can explain it? I'm going to explain it again. Basically, the main concept here is that the airways, the resistance to airflow to the lungs, a majority of that is coming in the first couple of generations of bronchi, right? Because you understand how they all divide and they get bigger. It's the anatomy of the lung, right? So this is the first, let's say 4 generations, these dots, right? Yes, they're dividing, but when you sum up their total diameter, it's getting smaller. And a smaller diameter or a smaller radius means more resistance. It's the same thing as like hemodynamics and blood flow. Smaller means more resistance, okay? However, after, let's say, the 4th generation, there are so many bronchi from the divisions that when you sum up all of their diameters together, it's actually greater than the one previous to it. And a big diameter means less resistance to airflow, means that there's going to be more air flowing easily, okay? So the main concept of the first graph, okay, is that a majority of the resistance to the airflow into the lungs comes from the upper airways. 80% of it is from the upper airways. After you pass the upper airways, there's almost no resistance to airflow. It decreases because there's so many bronchi that their sum of the radiuses together is huge. All right. And in the second graph, it's pretty much saying the same thing, right? Here we're looking from resistance from mouth and generations of airway. And you can see that the resistance at the segmental bronchi, which is the resistance from mouth. You know what? Actually, this graph is going to confuse you guys. I don't think it's important to go over it. I think if you get this concept here, this will be clearer for you guys. So do you understand this? Do you understand graph A? Because I'm going to explain graph B in the next slide with the clinical significance. Okay. So we're going to go over something called the silent lung zone. Okay. The silent lung zone is basically what it's saying is because most of the resistance to air, the airways is in the upper airways, it's going to be difficult for us to understand if we have a tumor. So stay with me here. A large peripheral tumor would be a tumor like at the terminal bronchioles, like at the very end of the airways. If we have a tumor there, right, because the diameters are larger and because there's no resistance to airflow, like almost no resistance to airflow there, it's not going to cause any symptoms. It's not going to cause any obstructive symptoms. So if you're measuring a patient's airway resistance and they have a tumor there, you're not going to see any changes because there's almost no resistance to airflow all the way down there. Okay, does that make sense? Okay, cool. So the other side of this is that if you have a small proximal tumor, so that's a tumor in the upper airways. Remember, the upper airways are what's determining a lot of the resistance to the airflow. So if you have a tumor on top of all of that resistance, it's going to cause huge changes and it's going to cause huge obstructive symptoms in the patients, right? So they're going to present way earlier because they're going to have so much difficulty breathing because they already have all this resistance in the upper airways. And on top of that, they're going to have a tumor there as well, which is obstructing any flow of air whatsoever. All right. So that means a proximal tumor or a tumor in the upper airways can be detected by airway resistance. But a tumor that's in the peripheral or in the periphery, like in the terminal bronchioles, cannot be detected by measuring airway resistance due to the fact that there's such a huge diameter and it's not going to cause as many symptoms as a proximal tumor would. Is that clear?
Yes.
Okay. So just for note, unfortunately, a lot of the tumors that patients get are going to be these. They're going to be the large peripheral tumors, and it's going to be the ones that are not going to present as early because that's where tumors normally arise. All right. These are a lot more rare. Moving on to our next slide. Now, this slide, I would say, is probably among the more important ones from this lecture. And if you were not paying attention previously, focus with me now. The tumor increases resistance. The tumor is causing an obstruction. So like if I were to draw, like, for example, like an airway like this, and you have a tumor like this, the air is not going to be able to flow well. You get what I mean? And the reason that this is a problem in upper airways is because so much of the resistance to airflow, so much of what's making it difficult for air to get from the atmosphere to the lungs is the upper airways, right? So if you already have a lot of that resistance there naturally, and you put a tumor on top of that, it's going to be really difficult for the patient to breathe. Does that make sense? Yeah, yes, I would say yes. It's not technically increasing the resistance, it's just obstructing the airflow. It's fully like, It's just stopping the air from moving because there's something there blocking it. You get what I mean? All right, I'm going to move on to this factors affecting airway resistance. So these 5 factors, right, stick to your memory because they are very easy to bring MCQs on. All right, so we're going to go through each of them one by one. First is density and viscosity of the inspired gas. And honestly, among this list of 5, the least important, but just thinking about it, if you have less density, right, it's going to be easier to breathe the air, which means that you're going to have less resistance to the air moving into your body. So an example of decreased density of air would be high altitudes. So like up in the mountains, the air is less dense, and that means that there's going to be less resistance to the air getting into your body. It's just easier to breathe it in. Now, there's actually less oxygen in that air, so it's not great for your lungs, but it's like pulmonologically speaking, it's not a word. You get what I mean? It's technically easier to breathe because there's less resistance. Now, reduction in PCO2 is one that confused me a lot in first year, because reduction in PCO2 actually increases airway resistance, right? And if you think about it, you're like, if I have less PCO2, right, I have less carbon dioxide, why would I want to increase the resistance? That means I'm getting oxygen. So why would I want to increase the resistance? Why would I want to get less oxygen? Actually, what's happening here is that not every segment of the lung is getting oxygen equal to each other. So one part of the lung might be getting more oxygen than another part of the lung, okay? So if one part of the lung gets a lot of oxygen, that means it has a reduction in PCO2. And that means that there's another segment of the lung that's not getting a lot of oxygen. So we have a system in place to sort of shunt the oxygen to the parts of the lung that are not getting as much air. So if one section of the lung is getting a lot of oxygen, it's going to bronchoconstrict, right? It's going to cause some smooth muscles to constrict, which means that that segment of the lung is no longer going to get as much oxygen, which is going to allow for the oxygen to go to another part of the lung that needs more. Right? Does that make sense? Okay, so that concept is called homogeneous ventilation. And that just means it's this sort of reflex, it's not really a reflex, but this sort of safety measure is there to make sure that the entire lung is being ventilated in the same way, and to make sure that not just one lung is getting everything and the other parts of the lung are not getting any oxygen. Lung volume, we're going to come back to in the next slide because this is a big key concept. As for agents, right, this is going to be things like drugs. There are a couple of drugs that were mentioned in the lecture that acts as bronchoconstrictors. So I think it's important for you guys to memorize them. So things like histamine, right? So like an allergy, right? When you have an allergy, histamine is released. And you know, when a lot of people have an allergy, their throat closes up, right? That is histamine, right? Is acting on receptors in the throat, and that's causing bronchoconstrictors. Acetylcholine, thromboxane, A2, prostaglandins, leukotrienes, all of these are bronchoconstrictors. You don't really need to understand when we have oxygen, we constrict, and more carbon, more dilation. So when you have oxygen, a lot of oxygen, it's going to constrict to move that oxygen somewhere else. As for carbon, yes, if you have carbon, I guess you could say it would cause more dilation because you're trying to get more oxygen into the body. All right, is that clear? Where was I? Yeah, for the agents. There's a lot of agents that can cause bronchoconstriction. There's a lot of agents that can cause bronchodilation. I would say stick to memory the ones that were mentioned in your slides, which were histamine, acetylcholine, thromboxane, leukotrienes, and prostaglandin, I believe. Yeah. Just know those because it's an easy MCQ to say like which of the following will cause bronchoconstriction and then put like one of these. As for like fully understanding them, I say make sure you understand everything else, and then if you have the time, go and learn what those things really are. Last but not least is the sympathetic and parasympathetic innervation. Now I put this GIF here for a reason, not just because I like Pokemon. In this GIF, the Pokemon is using Trick Room, which means that the opposite is going to happen in the battle. That's what's happening with the parasympathetic and sympathetic innervation in the pulmonary system. Now, every medical student has committed to their memory, like, oh, sympathetic is going to cause like vasoconstriction and parasympathetic is going to cause vasodilation. It's the opposite in the pulmonary system. Actually, sympathetic innervation is going to cause bronchodilation, and parasympathetic innervation is going to cause bronchoconstriction. So don't mix it up in the pulmonary system that the sympathetic and technically doing the opposite of what they would do in blood vessels. Does that make sense? Okay, thank you. So now moving on, another key concept in this lecture, and one that's pretty important for you guys. So as you learned yesterday, we know that alveoli and the lungs in general always want to collapse inwards, right? And this is not a bad thing, actually. It's a good thing. The reason that it's a good thing is that that force of wanting to collapse inward is actually going to push or actually going to pull open things that are present in the lung, right? So it's going to pull open the bronchus and it's going to pull open blood vessels, all right? And that's good because we want these things to be open to allow for air to flow, to allow for blood to move, to allow for ventilation, you know? So the forced recoil, right, which is, or the elastic recoil, which is the feature of the lung, is going to allow for the airways and the blood vessels to remain open. Now, what you need to understand here is that increased lung volume, right? So that means you're breathing in, you're increasing the lung volume. That is going to decrease compliance. And we learned this in yesterday's lecture. It's going to decrease compliance because you don't want your lungs to take in so much air. They have to stop at some point. Your lungs can't take in air forever, so they're going to stop being compliant. So you're increasing your lung volume, you're decreasing your compliance, and that means you're increasing your recoil force. And remember, the recoil force is what's pulling open or pulling them more open, these blood vessels and these bronchi, right? So we're increasing our lung volume, we're decreasing our compliance, and we're increasing our recoil force. That means that an increased lung volume or an increased recoil force means less resistance. So what you guys need to understand here is that increased lung volume equals decreased resistance. Okay. I'm lagging again. Oh no. Did you guys miss the concept or did you get it?
No, it was fine.
Okay. So key idea here is that increased lung volume is going to decrease resistance because remember, we're breathing in, right? We're decreasing the compliance of our lungs. Our lungs want to recoil. They want to, they want to close. And that recoil force is going to pull these open. All right. That pulling those open means that we have less resistance. They're wider. That's the radius again. It's the same concept. We're just talking about the radius over and over and over again. Okay. Do you guys get that before I tell you about the clinical connection here?
What mean by increase recoil force?
So basically, the lungs have this feature that they always want to go back, they always want to collapse, okay? But in doing so, right, they're actually pulling the blood vessels and they're pulling the bronchi open. And I know it's really confusing, this picture, because I was really confused about it yesterday, but just try to get the concept in your head that the lungs feature to want to recoil and go back is what's pulling these things open. Does that make sense?
Yes.
Okay. So now for the pathology of this, now we understand that increased lung volume decreases resistance. Okay. Increased lung volume decreases resistance because it's important. In patients with emphysema, first of all, do you guys know what emphysema is? Because it was mentioned in a couple lectures, but I don't know if you guys covered it. Okay, you know what emphysema is. It's great. So in patients with emphysema, right, they have an obstructive lung disease, and an obstructive lung disease means they have difficulty exhaling. Okay, so in a patient with emphysema, the way that their body naturally responds to sort of make things easier for them is to breathe at a higher volume than FRC. okay? That means that they're gonna have, when they finish exhaling and they get to FRC, normally we have around like how many liters? 3 liters in our lungs, right? They're gonna have 4, 5. They're gonna have more air in their lungs even after exhaling. The reason for this is because they are trying to increase their lung volume, okay? And by increasing their lung volume, it's gonna make breathing easier because it's gonna decrease the resistance. So that's why patients with emphysema are going to have hyperinflated lungs. Their lungs are going to be really big because they're keeping a lot of air inside their lungs. Does that make sense? High compliance. It's more of a pathology thing. Okay, so I'm going to repeat the emphysema thing. Basically,
I meant that people like who have emphysema disease, they have higher compliance than those who don't have this disease, since like we kind of like overstretch them. You know what I mean?
pretty much, yeah. That's basically, yeah. That's a great like summary of what's going on in emphysema. So their lungs are going to be a lot bigger. And we learned in this concept that increased lung volume is going to decrease the resistance. And patients with emphysema want as little resistance as possible. They're already having a lot of difficulty breathing, so they need to do whatever they can to decrease the resistance of the air movement, right? So the way that they do that is that patients with emphysema are going to naturally be breathing with a higher lung volume than normal people or normal healthy people would have. So for example, if we have 3 liters of air in our lungs, normally after exhaling at FRC, patients with emphysema will have 4 or 5, okay? Because they want to have a more volume of air in their lungs to allow for less resistance, to allow breathing to be a lot easier for them. Is that clear to those who didn't get it? Okay, I'm going to move on to the next slide. Okay, so this slide is the same exact thing that I was just saying in the previous slide, okay? As we increase the volume, here we have volume on the x-axis, and here we have resistance on the y-axis. As we increase the volume, as we're moving this way, the resistance gets less. And it's for that concept. It's because as we increase the volume, there's going to be more elastic recoil. More elastic recoil means we're pulling the blood vessels, we're pulling the bronchi more. They're staying open, they have a wider diameter, there's less resistance. Okay? So increasing lung volume decreases resistance, period. Now, a patient with emphysema, this is the normal patient right here, right? FRC. Patient with emphysema, their FRC would be like here. That's going to be emphysema. That's what I meant by when I say that they breathe at a higher lung volume. They retain more air in their lungs. Did we get that? Okay, yay, excellent. I'm glad. So it's not a PAL session without a practice question. Which of the following factors is going to increase airway resistance? Type it privately so that others don't see your answers. Okay, I'm getting some answers. All right, getting mixed answers. So we're going to go through them one by one. Okay. A is suboceanic altitude. That's low. There's going to be higher density. All right. Also, again, I said density was not very important. So it's unlikely they're going to ask you something like this. So if you see an option like this in the option, like if you see an option like this, unless you eliminated everything else for a good reason, it's most likely not that. Suboceanic altitude is low. The density of the air will most likely be higher. All right. It's going to increase the air or, oh, wow. Wait, I made this question wrong. A is correct. A is correct. Wait, let me check. Because oh no. Oh, this is really embarrassing for me. Hold on. Yeah. Okay. A is correct. A is correct. So those who answered A, you're right. That's embarrassing for me. B is wrong though. B is wrong because we said sympathetic stimulation is going to cause bronchodilation. It's going to decrease resistance. Salbutamol is a bronchodilator. It's going to decrease resistance. So I'm so embarrassed. Yesterday, Yazan couldn't do half plus half. Today, I make a question wrong. Guys, GI got us. Anyway, salbutamol is a bronchodilator. It's going to decrease resistance. A well-ventilated segment of the lung means that there's going to be less PCO2. And remember from that segment that I showed you, less PCO2 means that you're going to have constriction to shunt the oxygen to another place, which means that you're going to have increased airway resistance. So do we get why A and D are correct? No? No to what? Okay, which parts did I need you guys to tell me which parts you didn't understand so I can explain it. Okay, I wish you didn't ask about A. A is a mistake on my part, okay? Because you know what? I'm gonna change A. I'm gonna change suboceanic altitude. This option is not suboceanic altitude. This option is high altitude. Okay? High altitude. That's what this was meant to say. This was meant to say high altitude. C is a bronchodilator. C, okay, do you know what salbutamol is? Salbutamol is an inhaler. It's like what people with asthma use. Salbutamol is an inhaler that bronchodilates, that opens it. It's going to decrease airway resistance. The question is asking what's going to increase airway resistance. No, it wasn't mentioned in the LEC. That's the reason I put it, because you guys also need to know. If something is, I was getting there. If something is not mentioned and you see it in your options, it's never going to be the correct answer. Listen, don't get mad at me. These are how questions are asked. Okay. Yeah. Listen, I'm just, the answer is D. This is not, the answer is D. The answer is, I'm going to go back and explain everything again because I feel like I confused you guys. This says high. This says high, not sub. High altitude, decreased density. Decreased density of the air means decreased resistance. There's decreased airway resistance. A is not correct. Okay. Sympathetic stimulation causes bronchodilation. It's the opposite of what it does to blood vessels. It causes bronchodilation. This is incorrect. This is going to decrease airway resistance. Salbutamol is an inhaler, which means it's a bronchodilator. It's what people with asthma use. It's like those little blue things, right? People with asthma use. That's a bronchodilator. It's going to decrease airway resistance. It's not correct. A well-ventilated segment of the lung. What does that mean? That means that there is a section of the lung that is not receiving as much carbon dioxide. Okay, and remember we said in this slide, where? Here. In this slide, a reduction in carbon dioxide is going to increase airway resistance. No, there's other questions at the end of the lecture. I have another part of the lecture. But this is going to increase airway resistance, right? The reason for that is because you're going to shunt the oxygen from the well-ventilated part of the lung to another part of the lung that's not well-ventilated, right? So D, which is a well-ventilated segment of the lung, is going to be, or is going to cause increased airway resistance. Do you understand? Okay. Then my other tip for this, if you see something that you know you didn't take, it's not the answer. The questions are difficult in the exams, yes, but they will never put something that you didn't take somewhere. And if they did, you can always appeal it. All right. The reason I put salbutamol in here is because some people will always choose like whatever sounds fanciest. And I know because I used to do this in first year. It's not the case. Don't choose the answer that you know you have no idea about. Think your way through it. Anyways, we have a checkpoint now. Do you guys want to break or do you want to continue? This next part of the lecture is way shorter. So it's up to you guys. I'm fine with continuing. Is everyone okay with continuing? I need a couple more responses. 2 more yeses. Okay. Moving on to the next lecture, assessing pulmonary function. All right. This lecture is a lot less confusing. Alhamdulillah. I hope I don't mess up again. So now we're going to talk about spirometry, which is this machine that you guys are seeing here. This is like pretty much the easiest, like gold standard thing to assess anyone's pulmonary function, to assess how their lung and how their breathing is going. So basically what they do is that they have this thing in their mouth, right? And they're just asked to breathe and it's graphed for them. So at the beginning, they're going to be breathing normally, right? And then you're going to ask them, can you exhale as much as possible? It's going to take them all the way down to this residual volume. And then you're going to tell them, okay, now I want you to inhale as much as possible up until their total lung capacity. After they inhale to their total lung capacity, this is when you're going to be able to start like clinically diagnosing things. You're going to tell them now, breathe out as hard as you can and as fast as you can. Okay. And you're going to get 2 very important values. And also pretty much the only 2 values that really matter on this graph. You're going to get the forced expiratory volume in 1 second, and you're going to get the forced vital capacity. Basically, what these 2 numbers are is how much can you exhale and how much are you exhaling in the first second. Okay. Normally, we exhale about 80% of our lung volume. Like if we breathe up to our maximum, we exhale 80% of our lung volume in the first second of exhaling. That is a normal thing. You want to exhale about 80% of your lung volume in the first second. And then the rest of it happens, the last 20% happens after that first second. So honestly, the way that I understood this, and I'm going to ask you guys to do this with me, is I want you all to breathe in to your maximal lung capacity and hold your breath as long as you can, and then exhale. Okay, I didn't hold my breath as long as I can, but I didn't want to take long. You see how when I exhaled just then, most of it came out almost immediately? That's what's happening in FEV1. Most of the air in your lung is going to come out in that first second. Okay? So do we understand what these 2 values are? Because FEV1 and FVC are going to be everything. Like, okay, cool. So now let's talk about the 2 classifications of lung diseases. Can you repeat you exhaling and inhaling? You want me to just breathe? I mean, I've been doing that for the whole lecture. But if that's an actual like question, I will be free to Thank you. Now let's talk about obstructive and restrictive diseases. Okay, so I'm going to simplify this for you guys as much as I possibly can. Put it in your head that like this is a very, very like dumbed down version of obstructive and restrictive diseases. Obstructive is an issue with exhaling. Okay. Restrictive is an issue with inhaling. That is like, if you watered down these diseases to the simplest thing that they could be, that's what they would be. Okay. Now let's go over these graphs and let's talk about what's going on here with these numbers. So here we have a normal patient in graph A. Okay. So they did the spirometry. The physicians told them exhale as hard as you can. They got their FEV1, right? Which is this, or sometimes by the way, they just call it FEV sometimes, but it's always in the first second. They got their FEV and it was 4.0, and they got their FVC and it was 5. They divided 4.0 by 5, it gave them 80%. Okay, that's normal. That's what's happening. Now, remember, a patient with an obstructive lung disease, okay, is going to have an issue with exhaling. So when you tell this patient, hey, exhale, they're going to get barely anything out in that first second, okay? They're struggling. They can't exhale. It's an issue with breathing out. They're going to get barely anything out exhaling. With time, they're going to be able to get most of the air out, but look, they're never going to get to the point that a normal person would, okay? Because remember, their lungs are saving that air. Their lungs are at a higher lung volume than a normal person is. So if we take their FEV1 and we divide it by their FVC, for example, the numbers given here were 1.3 and 3.1, you're going to get 42%. Okay, what's really important to understand here, and okay, yeah, I'll tell it to you guys like this. If you see above 80%, it's most likely a restrictive disease, okay? If you see below 80%, it's going to be an obstructive disease, okay? Now, restrictive diseases, they can be a little trickier because sometimes restrictive diseases can be 80%, but you're probably not going to get questions like that in first year. And also, if they do give you normal, read what's going on with the patient. Obviously, a normal patient is not going to have difficulty breathing and stuff like that. Anyways, back to this graph. So we're at graph C now, right? The issue in restrictive lung diseases is that their lungs are pretty much completely messed up, right? They're not compliant, they can't hold air, their lungs are becoming like they're fibrosing. Their lungs are like fully losing their function to work as they normally would. And so that's going to reduce everything across the board, right? Both their FEV1 and their FVC is going to be messed up because they're barely inhaling enough air. They're struggling, keeping the air in. It's just a very bad thing. So what's going to happen in FEV1 and FVC is that both of these things are going to decrease. And with both of them decreasing, you're going to actually get a higher ratio, which is going to be above 80%, so 90%. Do we understand these graphs? These are very easy questions to ask, okay? Good, and you guys understand how to differentiate now between obstructive and restrictive, correct? Just remember, you always want to look at FEV1 over FVC. Can you repeat the restrictive one? Okay, so in restrictive lung diseases, what's happening to the lungs, and I don't think you guys have been taught like an actual restrictive lung disease, so just generally, what's happening to the lungs is that they're just not going to work in the way that they should. They're either becoming fibrosis, like their lungs are fibrosing, their lungs are not working, okay? Their lungs cannot take in air. You cannot inhale properly because their lungs cannot handle taking in air. This is going to reduce everything across the board, okay? Like their forced, like expiratory volume in 1 second is going to be decreased, but on top of that, their forced vital capacity, which is how much air they can exhale, is going to be decreased too because they could not get the air inside their lungs in the first place, okay? Now, FEV1 to FVC is a ratio, okay? So having both of these decrease at the same time is actually going to increase the ratio. Does that make sense? Okay. I want the guy or the person who said okay, yeah, cool. So moving on to the next graph. Here's just a table that I got from online. So obstructive, reduction in airflow, shortness in breath, and exhaling air. You cannot exhale the air, okay? Some examples of this are here. The only one that you guys need to know is emphysema, which is under COPD, by the way, but it's emphysema. That's the one that you guys were taught. That's the only one you need to know. Restrictive is a reduction in the lung volume. So remember how I said that the lungs cannot work in the way that they normally do? They can't take in air. So there's difficulty in taking in air inside the lungs because the tissue of the lungs are fibrosing. They're becoming more stiff. They're not able to take air. You don't need to know any of these. But this is just a table to help you understand that what is happening. What's the issue with obstructive? The issue is exhaling. What's the issue with restrictive? The issue is inhaling. Okay. So here is just another graph of ways that you can diagnose restrictive obstructive lung diseases. And this graph is not super important, but I want to tell you guys about teach you what the guy's doctors, what am I saying? Teach you what the doctor said. So this graph is putting the flow, which is like, the movement over the lung volume. So what you're going to ask to do is you're going to ask the patient, can you inhale as much as possible? Okay, the patient inhaled as much as possible. Now tell them, exhale as fast as you can and as hard as you can. And that's going to see how the flow is initially super high at the beginning. And then as you exhale more and more and more, the flow decreases. And of course, the lung volume is decreasing as well. Because remember what we said, in FEV1, that's when 80% of the air is getting out. That's when there's the most flow. You're getting the most air out of your system. So do we just get how this graph is being made first of all, before I explain the other parts of it? Okay, cool. So how they use this graph clinically is that they just get the patient, they're like, okay, breathe in as hard as you can, exhale as hard and fast as you can, and I want to see they're looking for these things. Their forced expiratory flow. I want to see your forced expiratory flow, which is how much force you're putting, or how much flow is coming out. 75% of the lung volume, 50% of the lung volume, 25% of the lung volume. Just they're seeing how the flow is. It should be, there should be a lot of flow at the start and, less at the ending. Again, FEF 75, 50, 25 is not really used anywhere. It's just more of like a theoretical thing. Really what the clinical correlation is here is that a lot of patients who work in, let's say like coal mines or like any place that could expose a patient to risks to their lung, they try to outsmart the doctor by going in, and the doctor's like, okay, we're going to do this test on you. And then the patient will purposefully mess it up. So that's what 2 is here. The patient is putting less effort into breathing into maximally and less effort into breathing out. And in minimal effort, it's this even less than that, right? So the patients will try to abuse this so that they can get diagnosed with a lung disease and and retire early. Okay, and say like, oh, look, I have a lung disease because of my job. You have to let me retire and pay me. The way that we can combat this is the same thing that I talked about in the first slide, which is ask the patient, okay, can you breathe in as much as you can? And then tell them, don't breathe. Hold it, 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 until they cannot physically hold it anymore. And then ask them to exhale. They will not be able to, they'll not be able to mess it up. You're going to get the actual value. All right. And the actual value should look like the screen graph. Okay. And I think that's clear as is. So now let's look at the this graph, which is just showing obstructive and restrictive lung diseases in a flow volume curve. Okay. Basically, it's just showing how much is the flow, right, on the y-axis, same as the previous one. It's literally the same graph as the other one, just way more simplified, and the lung volume. Now, remember, we said patients with obstructive lung disease are always going to have a higher lung volume because they want to increase their lung volume to decrease the resistance to make breathing easier. So patients with restrictive lung disease are going to be here. Okay. And their flow is never going to get nearly as close as the flow of a normal person because they have an issue with exhaling. Okay. So they're going to breathe in. Okay. They breathed in, they got to here. They can't breathe in that much because their lungs are already filled with air. They're going to breathe out. They're going to get to here. That's it. Restrictive lung disease, remember, their lungs are completely messed up. So first of all, they can't even hold as much lung volume as a normal person. When they inhale, the flow is not increasing by that much. The lung volume is not increasing by that much because the lungs can't take it. When they exhale, again, not much is changing. Restrictive, it's all messed up. They can't breathe properly. And then a normal patient. Now, what you guys need to understand about this is that this is a very ideal theoretical graph. You're never going to get a graph like this with a patient because there is no feasible way for us to tell how much volume is in a person's lungs. Okay, we can't look at a person and be like, you can, but it's very invasive and no one is doing this normally in a day-to-day practice. You know what I mean? So you can't go and be like, oh yeah, I know this patient has 9 liters of oxygen in their lungs. So really what's going to happen is that they're all going to be plotted at the same point. So obstructive is going to look like that and restrictive is going to look like this. Okay. They're all going to be plotted on the same graph. But what's important is you understand how are things changing in obstructive diseases and how are things changing in restrictive diseases and how is that going to look here? Okay. So do you guys get that? Cool. So here is a crazy table that is terrifying, but relatively simple if we walk through it. We're going to start with obstructive lung diseases. Remember, we said obstructive lung diseases are an issue to exhalation, okay? There's an obstruction to breathing, to exhaling. That obstruction, like we said, is going to cause a decreased FEV1 over FVC. It's going to be less than 80%. Okay. Obstructive is easy. Everything is decreased across the board. Everything. Their forced vital capacity is decreased. Their FEV1 is decreased. Their ratio is decreased. Okay. And their peak expiratory flow rate, which is like how much they can breathe in, is decreased. Their flow after exhaling is decreased because remember, these values are talking about exhalation. They have an issue with exhalation. The slope of their curve is decreased. Maybe what's important here and what you guys need to remember is this. If you remember that for your level, that's enough. Okay? Restrictive pulmonary diseases are pretty much the same thing. I'm just kidding. They're literally exactly the opposite. I don't know why I said that. Their FVC is going to be decreased and their FEV1 is going to be decreased. Okay, we understand that. But they're both going to be decreased like a significant amount and in a similar way. Here in obstructive lung diseases, their FEV1 is getting decreased significantly more than their FVC. Here, they're both decreasing by this similar, like by a similar amount. That's why when you do the ratio and you do the division, you're going to get a normal to increased percentage. So you're going to get pretty much above 80%. I doubt they're going to give you a normal percentage at your level. Everything else is going to be normal. And you're going to tell me, wait, Ibrahim, if their issue is with breathing and their lungs are messed up, right? How come their expiratory flow is normal? How come all of this is normal? That doesn't make sense. The reason that it's all normal is because we are taking these values relative to the total lung capacity of that patient. And remember, the total lung capacity of a patient with restrictive lung disease is significantly decreased because that patient cannot inhale in the first place. So if you take these values relative to their total lung capacity, they're going to look normal, but they're not. Does that make sense? Okay. Clear. All right. Am I lagging? There's a large like lag between when I speak and when you guys chat, or maybe I'm boring you guys to sleep. Okay. Oh, my internet connection is unstable. Question for you guys. Has this slide been covered yet or anywhere in any of your lectures? Okay, he did cover it. Okay. Okay, so then I'm gonna explain it, and I think another tutor is gonna probably re-explain it too, but this was a part of my lecture, so I'm gonna cover it. Bear with me. For some reason, this concept is extremely confusing, but I'm gonna try my best to simplify it. Basically, what's happening here, all right, is that when we expire and when we forcefully expire, when we go, okay, we are using muscles to do so. We are using abdominal muscles, internal intercostal muscles, we're using accessory muscles, all of those things. Now, when these muscles contract, they're going to increase the pressure in the pleural space, right? So I want you guys to look here, like this graph here. Not exactly what I'm talking about, but let's say that when I am using these muscles to exhale, I'm moving this pressure of the pleural space up a bit. Remember, the pleural space pressure is not becoming positive. Never it's becoming positive. It's just getting less negative, okay? Now, this increase in pressure is going to travel to the alveoli. This is kind of the similar concept to the breathing cycle that I covered in the first slide. Right, so we travel to the alveoli. Now, the alveolar pressure, right, the pressure in the alveoli is going to be greater than the pressure in the pleural space. Again, same idea as the breathing cycle. The pressure in the alveoli is higher than the pressure in the pleural space. We need that pleural space to make sure that the lung is not collapsing on itself. So, like I mentioned, air likes to flow to an area of lower pressure. So, when our pleural space is getting less negative, we're getting more pressure, that pressure is being transmitted to our alveoli, okay? The alveoli are becoming more positive, and that means air is going to move out. All right, air wants to go to the less The air wants to go to a place with less pressure. When our alveoli are positive, the place with less pressure is outside our body in the atmosphere. First of all, does that make sense? Before I start talking about the rest of this. Okay, great. Now, when we are exhaling, air is moving along our airways, okay? You should know that while it's moving along our airways, the pressure is actually decreasing. So it's going to go, let's say this is +2, right? It's going to go +2, +1.5, blah, 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 right? Eventually, it's going to become equal to the pressure that's in the pleural space, okay? Remember, you don't want them to be equal to the pressure in the pleural space because the pleural space is what's keeping everything open. It's what's keeping everything together, right? When you reach the EPP, which is this right here, when you reach this equal pressure point, that means the pressure in the alveoli is equal to the pressure in the pleural space. Theoretically, this should cause a collapse. This should cause everything to mess up. This should cause, air should not be able to flow anymore because everything is equalized. Cool? Does that make sense? However, this does not happen in us. Yes, when we're breathing out, the pressure is decreasing as we're breathing out, but the point in time where the pressure is equal to our pleural space is so close to the opening of our airways that it does not affect us at all. Okay? Like, let's say that this is the mouth right here. It equalized right here. Khalas, the air already reached out. It's not going to affect anything. Does that make sense? Like the equal pressure point and stuff like that. Really, I'm glad because it took me forever to understand this. Okay, so I'm going to get into the pathology of it now, or like the disease states. When a patient has a disease, for example, emphysema, this equal pressure point, which we said was right here, actually gets moved back. Now their equal pressure point is here. And this is where the problem happens, right? The equal pressure point is moving closer to the alveoli, which is going to cause that obstruction because you're going to reach a point exhaling where the pressure in the alveoli and the pressure of the pleural space become equal, really near to the alveoli, but you still have so much airway left that the air has to get through, but it can't, right? And that's what makes exhalation difficult. And remember, once the airway closes, like from because when they're equal, right? When the pleural space becomes equal to the alveoli, and then the alveoli becomes less than the pleural space after that, the airways close. And there's nothing we can do about that. There's no muscle that's going to force it open. You need the pleural space to be less than the alveoli. Okay? So now we have a patient in a disease state. His equal pressure point was moved earlier. That's why he's having so much difficulty exhaling. Okay? So this is why, and you might get something like this in the question some, and that a patient with emphysema, a lot of the times they present and the way they breathe is like this. They breathe with pursed lips and they exhale really, really, really slowly. Now, they're not doing this consciously. They're doing this because their body is adapting to this. What that does is that it's going to shift the equal pressure point later, okay? And it's going to fix the pressure issues that are present in the alveoli and the pleural space, all right? That way, exhalation is easier. They're moving the equal pressure point closer to the mouth. So that's why patients with emphysema exhale with pursed lips like this. I'm not going to do it again. But did you guys get that? I'm going to give you the key idea now. But did you guys understand everything that I just said? Yes, the pursed lips is going to increase the pressure. So that means less pressure, like the pressure is not decreasing as much. You know what I mean? Like you're not going to reach the equal pressure point as early because you're increasing the pressure by piercing your lips. I want to do it again. Does that make sense? Okay, cool. Key idea here. When pleural pressure becomes greater than alveolar airway pressure, it compresses the airways, period. When the pleural pressure becomes greater than the alveolar pressure, the airway gets compressed. That is the idea here. Do you guys understand that? That's the main takeaway here. Yay. Okay. So now a practice question. It's a table question. This one I cannot mess up because I took the table from somewhere else. In normal, what do you mean by in normal? Also, if you're answering, answer me privately, please. So you don't see each other's answers. This is, by the way, the people larger than plaza. What? I don't understand. Okay, I'm starting to get some answers, but I want more. And 230,586. I mean the pleural pressure larger than alveoli compressor. Yes, that's normal. Yeah, normally. So normally if the pleural pressure becomes higher than the alveoli, that compresses it. That's just like a physics thing. But remember, the point where the pleural pressure becomes equal to the, hold on. The point where the pleural pressure becomes equal to the alveolar pressure is so near to the opening of the mouth that it doesn't cause anything, doesn't affect anything. I need more answers, by the way, you guys. I've gotten one. There's 17 of you. Is it too hard? Is this question too difficult? Or is there something you don't understand? So I can explain it. I will answer your question in a bit. To the one that is direct messaging me right now, I will answer your question. I'm just waiting for a bit more. Guys, come on. Okay, there we go. Now I'm getting a few more answers. One more answer, and then I'm going to give you guys the correct answer. You have to choose one. Choose one answer. All right, I'm going to start explaining. The correct answer is, it's A. All right, now let me explain to you guys why it's A. This is a question from Ambos, and this is about a patient, blah, blah, blah. We have all her history. Great. She has bronchi, cool. X-rays there. She has emphysema. That's what you guys needed to get from this question. She has emphysema. She has an obstructive lung disease. Now we're doing a pulmonary function test. What are we going to find? So let's go over what our findings are in an obstructive lung disease in total or in general. FEV1 decreased. Totally. The FEV1 has to be decreased because that's an exhaling issue. They're not going to be able to exhale. Their ratio, like I told you guys, FEV1 to FVC is decreased. It's less than 80% in obstructive lung diseases. Okay? So that's decreased. Now, total lung capacity, and this is for the person who asked me, shouldn't everything be decreased? Total lung capacity will actually be increased. And remember why this happens is because in a patient with emphysema and in a patient with obstructive lung disease, they're going to keep more air in their lungs. And actually, you can see it in this X-ray. This is not what a normal lungs looks like. I don't know how many X-rays you guys have seen of lungs, but this is, first of all, really black, which means that there's a lot of air in these lungs. And the lungs are huge. This is like a really big lung. That means that this is a lung that's holding a lot of air. So their total lung capacity are going to be increased because they're retaining more air so that they have less resistance to airflow. And we remember why that happens. And the residual volume, we said is going to be how much air is left after you exhale, right? Let's take like that, how much air is left after you maximally exhale. And remember, in a patient with emphysema, they are holding so much more air in their lungs. So even after they maximally exhale, the residual volume is still going to be more than a normal patient. Okay? So do we all understand why A is correct? Perfect. Any questions, concerns? That is the end of my lecture. So I will stick around for any questions, comments, concerns, feedback. Listen, I know I won't get into it now. But I'm here for questions. I believe we can stop the recording. And if there's no more questions, and I will stick around until 4:25.